Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect. Welcome you all for today's webinar on gestational trophoblastic disease. And the icon for today's webinar is Dr. Rajashri Katke, ma'am. And let me introduce the MOC or moderator of today's webinar, Dr. Ritu Santwani, ma'am. Ma'am has done MBBS, MD, FICOG, FIAOG, AMRCOG. Ma'am is currently a consultant obstetrician and gynecologist, IVF specialist, founder and CEO of 360 Degrees Healthcare Studio, infertility specialist. Ma'am is also part of NUHS Singapore, co-founder of MAAM and board member of SWWC. I welcome you, ma'am, and I hand over the session to you.
Thank you, Sahiti, and thank you, Shil Pharma, for providing the platform. Friends, as we all know, knowledge is power, and knowledge always increases by sharing. So, I'm here back again with my series. So, today, none other than my very dear friend, Dr. Rajeshri Katke, Professor Rajeshri Katke is with us.
Thank you.
So, today she is going to discuss with us regarding the gestational trophoblastic disease. I last week posted in my group that in which topic everyone want to listen, in which there are a lot of queries. So everybody asked me about the H-mole and thyroid. So I think कोई भी इससे अच्छा नहीं बता सकता जितना राजेश्री बता सकते हैं H-mole के लिए. H-mole, partial mole, gestational trophoblastic disease. These all are having lot of confusions from the beginners up to the experts.
Yes.
So today, Dr. Rajeshri is going to discuss with us regarding that. And I must mention here that being a very busy schedule, in spite of being a very busy schedule, Dr. Rajeshri has agreed to do this lecture within a very short notice of 2 days. See, friends, we all know making slides is not easy. Being a busy practitioner and she's in the government college, तो बहुत काम होता है, सभी को बहुत काम होता है. Lot of requests. I am also getting that, madam, why you have reduced the number of the webinars. So friends, what happened these days, not getting time to make the PPTs and that. So making a PPT is also a big task. So yeah, I will request Saiti to give the introduction of Rajeshri madam.
Yes,
No,
ma'am.
it's okay now. We will start.
No, little bit of introduction will be there.
Okay.
It's my privilege to introduce Dr. Katke, ma'am. Ma'am is professor, head of the unit of government.
Just 2-3 lines. I'm a professor.
Ma'am has worked as a principal investigator in ICMR, HRRC, JJH, and ma'am has around 150 papers were presented by her students and 100 plus publications, 330 plus citations in national and international journals, and also contribution to book chapters in Foxy Focus International Publication House, co-editor and associated editor of Book Foxy, faculty in various national and international conferences. Ma'am has received numerous number of awards, including Mumbai Achievers Award, World Record on London Commitment Certificate, and also
Saite. Saite, it's okay.
Yeah.
Okay. People knows me.
And only one specifically I want to mention that she has done the marvelous work. She was in the task force of that at the time of the COVID. So really hats off to you, my dear friend. I think I'm really lucky to have you as one of my very dear friend. So without wasting any time, now we are directly starting the session because I am getting some messages from the doctors of Bangladesh. They have joined. Yes, over to you, Dr. Rajeshri.
Yes. Thank you so much, Ritu and Saiti, for those kind words. And I'll share my screen, okay? Yes. Yes. So I am Dr. Ashri Katke, professor at Grand Government Medical College, Mumbai. Now if we can say that gestational trophoblastic disease, this is previously we used to feel that it's a vesicular mole and herediform mole, but now these are the group of uncommon conditions like premalignant like complete mole, partial mole, herediform mole, and then now its malignant version is with the invasive mole, choriocarcinoma, placental site trophoblastic tumor, and epithelioid trophoblastic tumor, invasive mole. So these are the things which are, because there are now green top guidelines of RCOG in 2020, and all the spectrum, and looking at the GTD has become a different viewpoint of that. So basically, GTD arises from the abnormal placental tissue. In addition to the histology, molecular genetic studies can help in the diagnostic pathway. This is very important because we are seeing many of the persistent GTDs, and that becoming a very big problem, and they may go into the malignant version of that. So early detection of the molar pregnancy by ultrasound has resulted in changes in clinical presentation and decreased morbidity from the uterine evacuation. This is the most important thing. Looks, just we'll have a little bit of the epidemiological.
Dr. Rajeshri, sorry to disturb you. Please make it full screen.
Yes, yes. Okay.
Huh.
Sorry. Yes, AC level. Yeah, I forgot this
No
time.
problem, no problem. Yes,
Yes.
yes, perfect,
Okay.
perfect.
Yes, okay. So, so basically the higher frequencies are reported in the Middle East and Africa. UK, we have 1 in 714, but the incidence of hereditiform varies from the, Asian countries, they are high, and the European countries, they are being the less in that. So the GTD spectrum has recently been expanded and also included a typical placental site nodule. These are the one things I would like to, highlight also in that. Risk factors, all we know that some of the adolescent, elderly women, because it goes with the extent of the ages, this thing, and prior molar pregnancy, frequent OC pill use, smoking, vitamin deficiency, especially the carotene deficiencies, there are increase into the paternal age. So clinical presentation is usually varying duration of the amenorrhea with the irregular bleeding. So basically, we are more, when the patient such comes, nowadays we are doing all the ultrasonography and all, and we are picking the vesicular moles or the hereditary-form moles in a very early gestations. So there are two types of the unmalignant conditions of these molar, is the complete molar pregnancy and complete molar and the partial molar. So in a complete, what it happens, the single sperm fertilizes to the empty egg. So we are having the chromosomes from the paternal side, and this paternal side, it gets multiplied. So basically we are having the diploid sets of the things in that. But in a partial mole, what it happens is that these the two sperms can they fertilizes with the egg, means there is the two paternal and the maternal side of the chromosomal things are there. So that is called as the triploid variations. So two sperm fertilizes a normal egg, meaning the developing pregnancy has three sets of the chromosomes, two from the father and one from the mother side. Okay. Rarely you can see this molar pregnancy with the in the ectopic pregnancy also, and with the twin pregnancy also in that. So basically all of us, we know that about these are the pictures and how it looks into the honeycomb like appearances and the sonography in that. I would like to highlight about this, what we are more worried as a clinician is that what is the post-molar evacuation. I'll speak it more detail. So basically with the complete mole, it takes a little bit of this time, and partial mole, it comes early, because basically there is a difference in between these two, is that in complete mole, we are not having any fetal parts, but in a partial, you are having some of the fetal components or the fetal parts will be there. So you will have a good prognosis with the partial mole than the complete mole in that. So there is a third variety also in that. Sometimes with this mole, the third is the hydropic abortion, means in which that you will the villi, they will form the extreme of the cystic formation, and that can lead like that can look like to the also differential diagnosis of the vesicular mole. So histologically, if you can say that complete mole has a fluoride cistern formation, trophoblastic proliferation, and absence of the fetal parts. This is very important thing. In contrast to the histological features are less marked in the partial mole, and some of the fetal part or the cells can be seen, or you can find it out with the this thing. But in a hydropic spontaneous abortion, it may mimic like the appearance of the partial mole. So sometimes we do a evacuation, some of the parts has been expelled it out. Patient comes, we have all of us, we have done dilatation and curettage, and the report comes like a partial mole also in that. So these are the some technical things. So basically, there is an increased risk of the abnormal gametogenesis, and that is giving rise to the any problems into the forming a molar pregnancy. So basically, the problem is with the mutations of the NLRP7 and the KHD C3L genes in that. The cytogenetics is very important nowadays to get a prognosis in that with the complete hereditary form mole and the partial hereditary form mole is that if in a complete mole you will get it has a 46 XX chromosome with both X chromosome from the paternal because it is fertilizing the empty egg in that. Whereas in a partial mole, you will get the maternal and paternal genetic origin, that is a triploid. And with the hydropic spontaneous abortion, it is from the both the sides. So it will be 40, it has 46 XX or XY from the both the parents. So this is the basic difference we are supposed to understand in that. And there is a microsatellite short tandem report, that is STR genotyping. Basically, this has a dendritic triploidy presentation respectively in that. A cyclin-dependent kinase inhibitor, that is P57. P57 is is absent into the complete mole, but it gives the nuclear staining in a partial mole. So in a rare cases, if you want to settle a diagnosis and you want to see for the staining and all, so P57 it gives the more marker in that. So let's look about the clinical presentation. All we are know there is a period of amenorrhea is more than the gestational age. You can say that there is irregular vaginal bleeding. Either the patient comes with the first trimester or the second trimester. Then they are having hyperemesis gravidarum, preeclampsia, hyperthyroidism. So these are the things, and we subject it to the ultrasound in that, and we can see about the typical honeycomb appearances in that. Then how do molar pregnancies present to the clinician? So with the sometimes what is happen if suppose the patient is coming with the irregular vaginal bleeding and it's not settling with the things in the symptoms with that, then you can think of it could be the molar pregnancy with most of the higher degree of the hyperemesis, excessive uterine enlargement, hyperthyroidism, and early onset of the preeclampsia in that. So, as good as GTN in a non-molar pregnancy, basically, a molar pregnancy more develops with the GTN in that. So, aside from the postpartum abnormal vaginal delivery, vaginal bleeding, patients can present with the metastasis. We have seen patients, they are coming with the liver mets, brain mets, and unusual presentation or seizures, and they are coming with the convulsions and all. So let's have a look in that how the FIGO has been staged. So stage 1 is gestational trophoblastic tumor strictly confined to the uterine corpus. Then second, extending to the adenixa to the side and to the vagina. And third, it will go to the lungs and the GI involvement. And fourth will be the metastatic sites in that. So this I would like to highlight is in that FIGO scoring is very important. Either you are seeing about the whether high risk cases or the whether the patient is in a high risk group or not. So age, see age is if it is more than 40, it is going to give more marks in that. Antecedent pregnancy is very important. If suppose there is a molar, then abortion and the birth, so the degree increases, the score will go increases in that. Then the interval of the months in that, if suppose if you are having less than 4 months, then you will have a 0 score. 4 to 7 it will be 1, 7 to 3, 7 to 13 will be 2, and more than 13 will be a higher degree. Then beta hCG level serum, which is very important in that, because in some cases we are getting a lots of higher ranges of the beta hCG, and that is also one most important component. It will start 10⁻³ at the 0 level, then 10⁻³ to 10⁻⁵. And if we add the at the score 3, 4, it will be more than 10⁻⁵. Then sometimes you are having a largest tumor size, if suppose they have been developed a tumor mass in that. So whether it is less than 3 centimeter, 3 to 5 will be a 3 to less than 5 will be 1, more than 5 will be a 2, and more than 5 to 7 will be the last one. Then comes to the number of metastases, 1 to 4, 5, 8 to 8, and more than 8. So basically, this I just highlighted because now we are going with the newer concept. Suppose the score is around 13 or greater, so death is very likely, in a early form. So early death will be there. But if suppose the score is 6 or less, it is almost, if you are giving a chemotherapy, then it will be of 100% of cure rate will be there. But a score of 7, then it will increase to the 94% of that. The score is very important. And even with the vesicular mole or hereditary form mole, previously we used to do in that before giving the prophylactic chemotherapy, we used to have the patients, they are coming with the invasive mole and all. I'm talking about the very past where we have not given the methotrexate as a prophylactic chemotherapy, but now we are with the high risk cases, we are giving that also in that. So basically, FIGO has stage into the low risk GTNs, then high risk GTNs in that. So low risk scores will be 5 to say 6, and score more than 7, it will go to the high risk one is that. The important thing is that the plateaued or rising of HCG levels enables the early detection or the progression of the complete or the partial to the GTN. See, what we are getting the patients, they are coming with the complete mole, they are coming with the partial mole, we are doing the evacuation, and then after that, if we doesn't do a follow-up, and in that, if suppose that patient goes to the GTN and lost a follow-up, she may come with the invasive mole, she may come with the another malignant form of that, and then it will be a life-threatening for her. So it is very important. I always teach, and I always tell to the to the youngsters that whenever you are done evacuation is not very important in a vesicular mole, but the follow-up is very important in that. Counseling to the patient is very important for that. So typically the absence of the fetal parts and the cystic appearances that leads to the complete molar pregnancy. So what is the FIGO criteria for diagnosing the post-molar gestational trophoblastic neoplasm? See, why I have highlighted is that, so when you should consider or when you should suspect, we have one is a high risk scoring of that. So we know about that, no, this patient will go to the high risk group of that. But sometimes with the follow-up, there are some cases where the HCG is not coming down, but it is forming the plateau. At least on the 4 measurements, like, 1 week, say 1 day, means at the post-evacuation first day, then 7th, 14, and the 21. Okay. So either it is being a plateaued, or if it is going in rising, then you have to get a suspicion that this is something going towards the GTNA. So whenever there is a follow-up SCG monitoring every 1 to 2 weeks, so you are supposed to be very proper in counseling the patients also, and you have to make a record of that in that. So we have seen then how to treat such patients, and other investigations I have not put because all of you are the practicing gynecologist, and also basically we should go with the all liver profile, kidney profile, all the investigations, serial beta HCG, ultrasound I have spoken on that, X-ray chest is very important. Then if it is required, then you can go for the MRI or the CT whenever it is required in that. So, so we have come with what is the histology, pathology, what is the high risk group, what is scoring system, what are the stages in that, and how one should go for the treatment. The most important thing is that whenever you feel that there is a V-mole, then you should go first investigate it, see for the all the complicated things, and then you can immediately go for the suction evacuation and the curettage. It is very important to do the suction evacuation whenever it is the person should be a trained one. He should understand how much is the height of the uterus, gestational age of that. If you have ultrasound, do it ultrasound guided, because here, because of the hormonal imbalance, because of the more hormone softening of the uterus and the height of the uterus, it is more than sometimes the period of the amenorrhea also. So it will be very difficult. You might perforate. There will be a bleeding. It can become a torrential bleeding also in that. So the person has to be, the blood has to be kept red. The person has to be experienced in that. So you can do about that. Okay. So removal of a molar pregnancy, what is the best method that I have told you? Suction evacuation we are doing with either the metal or the plastic cannula. If you are doing with the ultrasound guided, then it is very good for that. And sometimes in a partial mole with the suction evacuation, then it becomes difficult to take it out the fetal parts. Then you can take it out the fetal parts with the either home forceps or anything, but make sure that it is a very soft uterus. So you have to be very, very, very careful in that. So excessive vaginal bleeding can be associated with the surgical management with the molar pregnancies, but the use of oxytocin infusion prior to completion of the removal is not being recommended in worldwide, because they thought that there could be a tissue embolization in that. So this is very, very, very important. So in what circumstances should a repeat surgical removal is indicated, and what is the timing of that? See, most of the gynecologists, they have come across that they have done a complete complete evacuation surgically, and still patient is having bleeding, and you might need the again the second time. So with my experience, I am telling you, there are some cases where the vesicles, they are too much adherent to that, or sometimes it has gone into the myometrium also. You don't know about that, and then you can take it out as much as it is possible. And after that also, if the patient is bleeding, yeah, post-op chemotherapy if you are given, then again under coverage of the chemotherapy you can do if it is needed a second um, evacuation. This I am telling you out of the experience. We have seen, I had cases where we have done very complete. After that also, then patient has some of the, they have gone, there is a irregular bleeding PV or bleeding PV, and it is needed the evacuation for that. So which woman should be investigated for GTN after a non-molar pregnancy? So basically, when they are completely, they are having persistent vaginal bleeding, then beta HCG is rising, and bleeding has not been stopped in that. And suppose there is a development of any dyspnea, hemoptysis, seizures, paralysis, or biopsy of secondary deposits in the vagina. So whenever there is a vulval or the vaginal nodule is there, don't take the biopsy of the secondary deposits in the vagina. It can cause the hemorrhage, because it can erode the vessels, and then it will be a torrential bleeding. So it is not being recommended. So these are the things one should be very careful in that. There is a theoretical concern over the routine use of the oxytocin agent, including ergometrin, misoprostol, because of the potential tissue embolization and dissemination of the trophoblastic tissue through the venous system. So, most of the worldwide, this is being not recommended, even with the green top guidelines of the recently came 2020 with the RCOG. How should you suspect ectopic molar pregnancy in women? So basically, sometimes with the ectopic pregnancy, you will get the molar changes. Then it should be treated like how you treat with the ectopic pregnancy in that. So this is about the one conditions where there is a twin pregnancy of a viable fetus and a presumptive coexistent molar pregnancy is managed. How to manage is that, so the first thing is that one fetus is live and a good one, and the other is vesicular mole, or there is a there is you can say that molar pregnancy. Then you are supposed to conceal the mother very properly. Tell her that it may be because of the abnormal things in the placenta. So fetal karyotyping is very important in that. We don't know sometimes whether the other fetus is also having any problem or not in that. So with all these consequences, you can tell her, conceal her, and then you can see for the treatment whether she want to continue and what are the factors. If she continues in that, then the decision has to be taken by them. So this is about the surgical evacuation. Then how you should go about the post-evacuation surveillance. This is the one important thing where we are, we are more worried of that. So whenever you are doing a post-evacuation surveillance, I told you on the first 7, 49, 21 days, you can see the follow-up of that in that. But minimum for 6 months in a high-risk cases, you can see for the required, if it is required, you can go for the beta HCG levels also. And the second important thing is that she should not become pregnant, so give for the hormonal contraception for that. While still elevated, and every month for the after 6 months also, if there is a elevated, and you are giving the if the patient comes to you late also, then again you are supposed to do the beta HCG and see it to that. Though there are the given times about the beta HCG levels, but sometimes you will get the patient which has they are coming very early and still, but don't forget to see for the beta HCG levels. And the second important thing is the ultrasound monitoring, and third is the X-ray chest, or any she has a symptoms of dyspnea, breathlessness, like that only. So follow-up HCG monitoring every 1 to 2 weeks is essential for early diagnosis of the GTN. I have spoken about this. Because the risk of bleeding increases with the uterine size, so blood transfusion is very important in that. So don't touch the vesicles. If suppose it might, bleed profusely, so keep blood ready in that. There was one case where the blood was not being kept, and it was like that patient was referred to us, and she was negative blood group, and in a hurry of that they took it with that, and then after that there was a torrential bleed and problem was there. So whenever there is a negative woman, RH negative woman, give for the prophylaxis for that. Women are advised not to conceive until their follow-up is complete. This is very important. The follow-up should be completed. The beta HCG level has to come for the normal. So for the fertility or the conceive, you have to counsel them very properly. The women who undergo chemotherapy are advised not to conceive a year after completion of treatment as a precautionary measures in that. Then the overall risk of requiring chemotherapy for GTN is around 13 to 16%. Almost this is the data worldwide. This is the thing, but more with the complete molar pregnancy, and less will be with the partial molar pregnancy. There is a definite ABO blood group association which has a common in A and O groups of this. So FIGO criteria for diagnosis of the post-polar gestational trophoblastic neoplasia. So this is, I have explained to you the same thing. The FIGO has also been quoted in that days 1, 7, 14 to 21. And HCG lasts for the 4 measures, whether it is having a plateau formation, or suppose there is a rise in a HCG for 3 consecutive weekly measurements, so these are the things where you will think of, either it is going into the GTN or early diagnosis of the choriocarcinoma in that. So what are the tools for investigation for the GTN? Chest X-ray, lung CT, liver metastasis, brain metastasis, MRI, CT scan. So these are the things we should do with that. So prophylactic administration of methotrexate or actinomycin D chemotherapy is important in a high risk groups, and that is going to help to the patients not going into the GTN. Then comes to the role of the surgery. So the surgery, we have seen about the suction evacuation. The second is about the hysterectomy. Can be considered. Sometimes some patients have uncontrolled uterine bleeding, and then it becomes very, very difficult to control it, and then you should take this, opportunity. I mean, take this method to save her life. Minimally invasive versus open abdominal hysterectomy. All we know that minimally invasive surgeries, they have a shorter stay, less blood loss, and all. So that depends on the doctor's choice. Then laparotomy is needed whenever there is to stop the bleeding in organs such as liver, GIT tract, kidneys, and spleen. Sometimes if they have bleed in that, then you can go ahead with that. Neurosurgery is needed whenever there is a brain or the gamma knife stereotypic, you can say that radiotherapy and whole brain radiotherapy, it is needed if there is meds are there or not. there is one case I would like to say. There was so much of the huge bleeding. So with this, we have done. There was a patient was very pale also in that, and she was referred. To stop the bleeding, we gave a hemostatic radiation dose, because I told them to give this hemostatic radiation dose and it will come down. After that, we gave the means blood transfusion. We build up the hemoglobin and then we did the hysterectomy on her. So these are the very simple, we feel whenever we are this thing listening or when we are reading, we feel that okay, this is the very simple thing, but it is very, very difficult in the GTNs. Sometimes you don't know we treat like a complete mole and there is an invasive mole. Even sometimes the diagnostic modalities also can miss the things in that. So let's have some of the malignant things in that. One is a choriocarcinoma. Invasive and metastatic moles can be diagnosed. Hysterectomy you can do if it is she has completed all the family and all. So basically we know that this is a hemorrhagic and necrotic areas that gives on the histology and absent of the villi, and it can goes to the tubes, ovaries, lung, liver, spleen and kidney. Choriocarcinoma histologically shows absence of chorionic villi, and there is a presence of abnormal intermediate trophoblast and the cytotrophoblast, rimming with the necrosis and the hemorrhagic area. This is called as a variegated appearance and absence of the villi. That is the diagnostic of histological choriocarcinoma. The rare of the variety is that placental site trophoblastic tumor, though we have seen this. So this is, they might be having either a isolated nodule or there will be a diffuse nodules also in that. And these are the very radio resistant cases. So you have to diagnose it and you have to treat it very properly in that. So PSTT or the placental site trophoblastic tumor, it comes or the arises from the intermediate trophoblast on the maternal side of the placental vein. Okay. So these tumor cells are the irregular hyperchromatic nuclei, dense eosinophilic, cytoplasm and chorionic villi. In most of the tumors, you will have a chorionic villi are the absent one. Then comes to the epithelioid trophoblastic tumor. Grossly, the tumor appears as a white to brown discrete nodules, but basically what it happens, nearly half arise in the cervix or the lower uterine segment of the uterus, and they can be, you know, again with the chorionic type of the intermediate trophoblast. So this is one of the placental or there is a epithelioid trophoblastic tumor, though it is rare, but you can see the your cases into the tertiary centers or in the practices also in that. So here the most important thing is that the risk of recurrence in a later pregnancy is low if you can treat it if you can treat it the previous molar pregnancy properly in that. So low risk gestational trophoblastic neoplasia patients with the low risk. So they have the good prognosis in that, either with the methotrexate or the actinomycin D. We are using methotrexate, and if it is second line, we are using with the actinomycin D. So if suppose sometimes we have patients which are resistant to the methotrexate, then it can go to the second line of that. So higher the score, use the multiple or the combination of the chemotherapeutic agent. So yes, it's given a first single line agent of the chemotherapy, methotrexate, alternate with the folinic acid 1357 and 2468. Methotrexate, you can give 1 milligram per kg or the 50 milligram methotrexate intramuscularly, and alternate you can give the folinic acid for that, and see for the response with the beta HCG if it is coming down or she is responding. If it is not responding, then we use switch her with the actomycin D 1.25 milligram per meter square intravenously every 2 weeks. So it depends upon the you have to involve the, then if she is not responding to the plain methotrexate or combination of methotrexate with the actomycin D, then again you take the opinion of the medical oncologist and you can form it that if suppose she is going into the malignant version of the GTNs. This is for the low risk, but in a high risk, always it requires the multiple agent combination of the chemotherapy regimens. So we all know it is a very famous Semaco regime where that you have a etoposide, methotrexate, actinomycin, cyclophosphamide, and the vincristine in that. So patients, they do respond majority with the imaco regimes. So this is just for this thing. So how you can give is that in a day one, you can give with the etoposide, actinomycin, and methotrexate. Sorry. Okay. And day two, again, you can give with the this thing, and you can observe with the levels of the beta HCG, how she has been responded. So ultra high risk gestational trophoblastic neoplasm and the salvage therapy among the high risk groups. This is very important in that. With the salvage therapy means when they have a metastasis and it becomes very difficult to get in that. So basically you are supposed to go with the salvage therapy. And suppose the patient has come with the brain metastasis. You know, brain metastasis that goes to the higher scores, and that then it becomes very difficult. Such patient, they present with the irregular bleeding PV, with the brain mets, seizures, convulsions, comatose condition, and all. So you can start with the imaco regime that has been used, or I have already told you whole brain radiotherapy around 3000 curie gray, or you can fractions, or you can use about the stereotactic or the gamma knife. We have used in one patient where the brain mets are there in our institute for this gamma knife. Okay. Then salvage therapy, we know all that all the various regimes with that. Either you should go with the cisplatinum, etoposide, actinomycin D, paclitaxel, methotrexate, bleomycin, etoposide. So these are the BEP regime, then VIP or ICE regime, high dose chemotherapy with autologous bone marrow stem cells transport. We don't go to that stage of that. We have used a combination of the chemotherapies and patient has come, but most of the patients, they have not responded also. And unfortunately, we lost them. So, and there is a role of the immunotherapy with pembrolizumab. These are the newer drugs, immunomodulators, where you can use that for the salvage therapy in that, okay, or in the resistant cases. So basically, placental style or the you can say that ETT and PSTT, they are less chemosensitive, so always go for the surgical one. Then the problem comes with the young patients, what to do for that. If suppose if you are doing with the fertility preservation is desired, especially in a localized lesion, then conservative management such as uterine curettage, hysteroscopic resection of that nodule with chemotherapy, when it comes down, then again you can try after 1 year, you can try for the fertility. So fertility preservation is not suitable in a diffuse lesions because the lesion is everywhere and you are giving a chemotherapy, and with chemotherapy sometimes it becomes very difficult to go with the fertility things. And suppose there is a diffuse lesions are there, definitely it is going to flare up and it might lead to a torrential bleed, or it might lead to a secondary metastasis. So what is the long-term outcome of women treated for GTN? Okay. So basically, if they are coming at early stages, then score is up to 6. I told you there is a overall chances of cure rate is around 100%. Then as future pregnancies, if they want to do in that, then if suppose the pregnancy with the low risk, if it is being cured with the 100%, then there are 80% chances of getting pregnant afterwards with the treatment. So the less the score, more the response to the chemotherapy, the earliest the HCG levels comes to the normal, and after that you can plan the pregnancy for the things. So basically, you are supposed to advise the lady not to become pregnant until they have completed their HCG, uh, all the HCG levels. Then advice on contraception after a molar pregnancy. See here about the contraception. If you can go for the either barrier or the hormonal, but you should not go for the IUCDs. You know, sometimes if you, but all these contraception also, it should come down the molar pregnancy. It should come down the plateau. If it is, you have to observe whether the beta HCG is coming down or not. The use of exogenous estrogens and other fertility drugs may be used if the HCG levels they have come normal and there is no lesion on sonography or on the CT scan. And the same rule is applicable for the human hormone replacement therapy. So what is the long-term outcome of women treated for GTN? So basically, the less the score, then there is a more the response and start the chemotherapy in that. After treatment of GTN, follow HCG monitoring. This I have spoken. These are the salvageable regimes. I put a slide of you go only that is that BEP, FAV, high dose, and all those these things. So this is the study in my center. I have done it. Means we have done it. Gestational trophoblastic disease and its complications. So what we have found is that the more they were with the complete vesicular mole cases, after that partial mole, and there was not a single case of choriocarcinoma because we have given all the methotrexate and chemotherapy to the high risk cases in that. So what we have used is that single dose methotrexate, multiple dose methotrexate, then IMACO regime, and chemotherapy is not required. I mean, no chemotherapy in 9 cases, and but we needed one with the IMACO regime, and for 10 cases we have used a multiple dose of the methotrexate in that. So this is for the young patients. We have done a post evacuation, post chemotherapy endometrial thickness to see that how they are, increasing in that. So we are having the 12 millimeter. It has come to the thickness. It has less than 12 millimeter. It has come to, and evacuation was also proper in that. So in those cases, we have seen about that. The most important thing is that it was an institutional study. So we have seen in that the patient they are coming, if you pick up in early and in the high risk cases, you give the methotrexate or the prophylactic chemotherapy, you can prevent the going into the extremes of the GTNs in that. This is this I have included. This is a case. This I reported also in that. This is the very atypical presentation of the uterine choriocarcinoma. Just for the couple of slides, I would like to show is that she was 26-year-old female, married for 9 years. She was G3, P2, L2, and she was having irregular bleeding per vagina since 1 month. Okay, so she was pale. Uterus was 10 to 12 week size. Then we did a evacuation. On ultrasound, it has shown as an incomplete abortion. We did a evacuation. There were a grossly product of conception, but some of the vesicles also were there in that. Okay, but after that, histopathologically also, they have seen that there is some of the vesicles which were adherent to the myometrium. So some of the cells they have found it in that. Her beta HCG levels were more than 2 lakhs. Okay. So after methotrexate, after evacuation, it has come to, after evacuation, it has come to 1,30,000. She was high risk. So I started with the prophylactic methotrexate. After 15 days of that, it has come to 71,000, and then it comes to 23,000. Post-operative, ultrasound showed everything was normal. But before that also, with the same, when she came with us, she is having the thyroid stimulating hormone TSH levels very low, 0.05, and she was having all the thyrotoxicosis, hyperthyroid symptoms with that. So we have put her on antithyroid drugs in that. So this was till this thing. But after the 25 days of the post chemotherapy, suddenly she was presented with the bleeding per vagina. The hemoglobin was around down in that. So we started with she was 26 years. She was very much interested in preserving the uterus. So again, we started with the chemotherapy for that with the multiple regimes, with the help of an oncologist and all. Her ultrasound Doppler showed that in the myometrium, all the myometrium has replaced with the large vascular spaces in that. And also, there is a formation of the nodule, or there is a myometrial invasion on the MRI. So here, when she is 26-year-old, to tell her, to conceal her for the hysterectomy, it was a very big thing. So I counsel them. It is not responding to the chemotherapy, not a single, multiple drug, change of the regimes and all. And it is, if she bleeds torrentially, we may come to at a very dangerous state. And we counseled in that, and she was, bleeding profusely. Even the oncologist, they said, she is not responding to the chemotherapy, and we have to go for the hysterectomy for her. And we did a total abdominal hysterectomy and a spinal. Intraoperative findings were the same. It has been, the disease was there, but there was no extra serosal spread there. She was, ovaries were normal looking on gross. And these are the pictures, in the ultrasound and the MRI also, if you can see in that. And this was the, the specimen when I cut after operation. See all this, it has been invaded into the myometrium. This, it has been, and very rapidly it has been formed and not responding to the chemotherapy. When the patient has presented as a incomplete abortion on sonography, we found some of the vesicles, some of the fetal part tissue. It was as good as a partial more. And but the beta HCG was 2 lakhs. Then after evacuation 1,30,000, and after chemotherapy of 15 days it has come to 71,000. But after, at the day 25, the disease again progressing, and she was bled profusely, and we could able to save with that. So these are the experiences. I thought this will be a very good thing to discuss this case. So I told this thing. I think last couple of slides, recommendations for the future research. So what we should do. So basically, when the patient comes with the irregular bleeding PV, amenorrhea, hyperemesis, hyperthyroidism like things, then you should go for the investigations for the good sonography, Doppler, tumor vascularity, ultrasound pulsatility index, and biology and the molecular mechanisms in predicting the molar pregnancies will resolve the issues spontaneously. Then persisted as a GTN or transform into the choriocarcinoma, PCTT or ETT. You should pick up such cases, the high risk cases, see for the score, and then you can go ahead with that. Pick them early, treat them early. Then evaluation of the use of the ultrasound at the time of the uterine removal of the molar pregnancies, it will reduce the perforation chances and all. Second, removal of the persistent gynecological symptoms, and she's think there is a need of the chemotherapy. Then etiology of the atypical PSN means placental site and all these atypical cases, then it is required as a multi-agent chemotherapy to eliminate their disease. Then go for the immunotherapies and understand the impact of the GTD on women. So not the impact on her, but basically it is the impact on her in her family. And it is very difficult if they are coming with the secondaries, it is very difficult to take for them. If the young patients they are coming, then preservation of fertility is one of the problem. At one end, there is a preservation of fertility. Second end, there is a progression to the GTN or the malignant version in that. So you have to be very careful in this thing, taking the decision. This is a very nice, references they have done with, this International Journal of Gynecology Obstetric, NHYS and all. They have done a very good study. Then these are COG Green Top guidelines. Then atypical presentation of uterine choriocarcinoma, that what I have, my 2 studies I have included. So what is the optimum follow-up following a disease of GTD? So basically, you should go with the, they said that it should revert within the 56 days of the pregnancy, but follow-up can go till the 6 months of that. So it's never too late to learn anything. Always, every patient teaches us, and with every patient, you learn a very good things. And so always be with, and this is for Dr. Ritu, because she is very much for, we both us also work for the knowledge sharing platform, and it is very good. She is doing a wonderful job for the medical fraternity to sharing the knowledge and calling me also on this platform. Thank you very much, Dr. Ritu, a lovable, very nice friend, and you can say excellent IVF specialist, one of the big name in the academic thing. And thanks, Sahiti, for giving the introduction. Thank you, Sheil. So here, thank you very much, all the audience and all. And thank you. God bless you all. I'll stop my sharing.
Thank you. Wonderful presentation.
Yes,
Rajeshri, you had
I wanted to simplify it.
You had covered each and everything. Means
Yes.
I'm really amazed that how you had made such a beautiful slides in a day.
Yes.
You had
Yes.
covered each and everything. especially the last portion what you have covered, how to give the drugs and dosage, that is really marvelous. So I
Yes.
had a one question I received in the YouTube. It is not actually a question, it is an appreciation. This is by Dr. Musarik Sheikh. He has joined from Dhaka. He is
Yes.
writing, Madam, he is actually in our academic group, huh, Rajeshri?
Yes. Yes. Yes.
So he is
Yes.
writing, Madam, please post 2-3 slides of that in the academic group. That
Yes. I will
dosage
share the
schedule,
presentation. I will
the
share
dosage,
this.
the dosage schedule.
Yes.
Huh?
Yes. Yes.
Huh?
Yes. I will. I will.
Another comment I have received from Dr. Romania. He has joined from Nigeria. He is
Yes.
writing wonderful presentation. Ritu
Thank you.
madam,
Thank you.
please keep, he's writing, Ritu madam, please keep on continuing such good sessions with such good speakers. Huh?
Arey wow. Thank you so much, sir. Thank you. Thank you.
Huh?
Thank you.
And one more comment we have received, Dr. Junarkar, not mentioned from where, joined.
Yes.
I don't know whether he or she. Huh? Very nice, madam. When are you arranging the sessions for the thyroid? So, okay,
Yes,
we
we
will
will do
go.
that also.
We will do that
Yes.
also.
Yes. Yes.
So, lovely presentation. I am
Thank you,
spelling
dear Ritu.
समझ में नहीं आ रहा है मैं इतना अच्छा है कि उसमें कोई क्वेरी ही नहीं है lovely presentation
Thank you. Thank you.
and क्वेश्चंस तो कोई भी नहीं आए हैं राजेश्वरी कोई भी
नहीं, it
क्वेश्चंस नहीं
is
आए
basically it is very difficult, but I made it very simplified because there
हाँ
are so many things which has come, and previously it was like that, we are having vesicular mole, do a evacuation, and then very rarely patient used to go to the carcinoma and all.
yeah
Means we have seen few cases in
हाँ
our residency,
हाँ
but now
see
there is a change of so
yeah
much of the epidemiology that
yeah
yes, yes,
Dr.
Abdul
Abdul Rahman has joined from Saudi Arabia. He has written a
Thank you,
comment
sir.
there.
Thank you very much for the
Thank
appreciation. Thank you
yeah,
very
thank you
much.
for joining also, Dr. Abdul.
Yes,
Thank you for joining
thank you.
also.
Yes,
Ritu ma'am,
So,
certificate.
yes, I remembered it. So, I
Arey वाह.
think, yeah. So this is
Wow,
a
this is
token of
wonderful.
appreciation. This is a token of appreciation to you, dear
So
Rajeshri,
nice of.
for sharing your excellent knowledge with us. And we
Yes,
are
yes,
really
thank you.
grateful to you. We are really
Yes,
grateful to
मुझे
you.
soft
हाँ
copy दे दो.
दे देंगे आपको भी सॉफ्ट कॉपी
Yes.
So
Yes.
thank you, Sahiti.
So,
And
Saiti, thank you.
I
Thank you,
think with this
Ritu.
we will wind up. Yeah,
Thank you,
there are
ma'am.
two
Yes.
questions. Yeah. So thank you, Sheel Pharma, and big thanks to Sahiti also. Sahiti is always
Yes,
ready to
yes, yes,
cooperate.
always
And
ready.
for making a flyer also in a day or so, in spite of there are so many webinars are going on. So
Yeah,
thank
yeah,
you
they are
once
busy.
again. Thank you once again. With this, we are winding off. Good night.
Yes, good night. Good